Sheikh. The next one is Dr. K. Naga Chaitanya. She is going to present a crush reversible.
Good morning, everyone. I am Dr. Naga Chaitanya. I am from Hyderabad, currently working in Kerala. To present case, she is a 63-year-old lady, diabetic and hypertensive. She presented with central chest pain of 10 hours duration. She was hemodynamically stable. Her ECG was normal, but echo showed wall motion in LAD territory with good LV function. Her trop was positive. So we took her up for an early CAG. So this was her angiogram, which showed 80% eccentric stenosis of mid-LAD involving ostium of a major diagonal, which is about 70% with Medina 011. And there is another discrete eccentric 90% lesion in mid-segment of the diagonal. So since the diagonal is a good caliber vessel supplying a major myocardial territory, we planned for an upfront two-stent strategy. So to see the strategy, coming to strategy, considering the bifurcation angle, we ruled out tap. So between QLO and crush, since the caliber is different of distal LAD and diagonal, we thought we will go for crush. So we planned a DK crush strategy. Due to financial constraints, we couldn't use imaging for this patient. So first we stented the mid-segment of diagonal, and then coming to the bifurcation, predilatation of LAD and diagonal ostium was done with 2.5 non-compliant balloon. Immediately after predilatation, patient had angina and she had angina and started having ST depressions and hypotension. So on check, we noticed that there was a dissection in diagonal with TIMI 1 flow. Unfortunately, I don't have that fluoro image. So we decided to stent the diagonal first. So LAD2 diagonal was stented with 3 into 23 mm DES. Then pot was done with 3.5 NC balloon. So this was the result after LAD diagonal stent. The ostium of LAD was compromised. Then the LAD was recrossed through a proximal strut. The strut was opened and serial dilatation done with 2 and 2.5 mm balloons. So LAD was stented using 2.5 into 28 mm DES. So we actually, since we stented LAD2 diagonal first, we changed the strategy to reverse crush technique. So LAD was stented using 2.5 into 28 mm DES simultaneously with a crushing balloon in LAD diagonal. That was 3 into 15 mm NC balloon. So after stenting LAD, we post-dilated the LAD and the wire and balloon were removed, and then the LAD stent was crushed with 3 into 15 NC balloon. Then the check angiogram was like this. There was slow flow in LAD and the LAD stent was well crushed, but we could see some hazy lesion in the mid-LAD. So we were not sure what was it. We continued with the bifurcation. Final kissing balloon was done with 2.5 mm NC balloon in LAD and 3 balloon in diagonal. And we again checked the angiogram to see the mid-LAD lesion. It was still hazy. So we have given vasodilators, but it was not resolving. So we suspected an intramural hematoma. And so we have stented it. An overlapping stent was done. And then final pot with 3.5 NC balloon. And this was the final result. So this is the final result. So DK crush, we all know it is the most extensively studied two-stent bifurcation technique, and it's proven superior to both TAP and QLO, and has good long-term outcomes. But having knowledge of all the bifurcation strategies is important to bail out any situation. And the optimal result mainly depends on the good stent expansion rather than which technique we use. Thank you.
Yeah, very good case. What was the history you said, the patient?
10 hours rest angina, ma'am.
Rest angina.
Yes.
Okay. Because on why the patient was not offered CABG? Because LAD was like looked like a CTO sort of, and diagonal is a like major branch. Yeah. So why not CABG? And second thing is imaging.
Imaging, they were not affordable, that's why we...
Okay. And another last question is about the decay crush. Now because the carina, because you are lucky enough that after the decay crush, the distal lesion you were able to cross with the stent and ballooning. But because I can see your diagonal stent is quite inside the main vessels. So in decay crush, we should aim for either mini crush or nano crush. So less strut of the stent branch should be protruding into the parent vessels, because then to cross with another stent and address the distal lesion must have a difficult task.
Yes, recrossing was difficult.
Yeah. Okay.
Yeah, one or two things like your diagonal was really big.
Big.
Yeah.
And osteal lesions are generally very fibrotic. You try to open them with high pressure with NC balloon, you end up dissecting. And then there your entire bifurcation strategies goes for a toss.
Yes.
So your main crux was starting with a dissected diagonal.
Yes.
It could have been prevented by using a cutting balloon.
balloon.
So that's number one. Number two, your mid-LAD lesion was either an extreme spasm or query dissection. Ideally, it could have been sorted by an imaging. But you said it could be an intramural hematoma.
Yes.
Intramural hematoma will worsen if you put more stents.
But
Ideally,
we actually
intramural-
overlap the entire...
Yeah. Ideally, intramural hematoma should be again cut. Use a cutting balloon, drain it.
Yes, right.
And your hematoma gets dissolved. But eventually you manage to get it better with a stent, so it looks more like probably an edge dissection.
Yes.
Yeah. Nice
And
case.
even when that overlapping stent was expanding, we could see the squeeze, and then we thought, yes, this was...
Yeah. Okay.
Thank you, Dr. Naga Chaitanya.